Hello, everyone. This is Chadi from RSH 2025. I'm really privileged to be with Dr. Ali Wazir to talk about the imaging aspect of planning for tricuspid valve regurgitation. Dr. Wazir, thanks for being with us.
Thank you very much. Thanks for the invitation to talk.
Yeah.
Um, Essentially, a privilege to be part of this program this year, and my interest is interventional echocardiography for transcatheter valve procedures, particularly on the tricuspid side.
Yeah.
So I gave a talk earlier this morning on the importance of this in terms of procedural success,
Yeah.
Particularly for ensuring that you, or one, selects the right patients.
Right. So as we know that tricuspid valve or any procedure, you have to do pre-planning, procedure, and post. So maybe we can dissect in these three segments.
Sure.
Starting by pre-planning or patient selection.
Great. So, if we have a patient who has severe tricuspid valve regurgitation, we first look at the transthoracic echo, consider doing a transesophageal echocardiogram, see what kind of pathology, the mechanism of the tricuspid valve regurgitation, understand which potential therapies this patient may benefit from. If we feel that there are potential transcatheter valve edge-to-edge repair type of patient, then we may not do further investigations other than perhaps performing a cardiovascular MRI and right heart catheterization. In a patient who we feel is more suitable towards replacement, then we'll start thinking about CT scanning them as well as the other imaging modalities I've just mentioned. The CT is very important in terms of the suitability and the anatomy, particularly looking at the tricuspid valve annulus on CT to see whether patients are suitable for example, the evoked valve from Edwards. So that would be part of our initial workup.
Is there a way, just before you move to the procedure imaging, is there a certain thing you see on imaging before the patient come on the table that say this is not a good case, this is not a good candidate? Like what are the red flags?
So we're very much interested in the LV and the RV function. So it's very important to have a good understanding of the RV dysfunction that majority of these patients have. But it's very difficult to tease out sometimes how bad things are. And another factor is patients have irreversible severe pulmonary hypertension. I think, again, that's another subgroup of patients who may not do well with the procedure in terms of the outcomes as suggested by published data. So those are probably the two key things that we think about: reversibility of pulmonary hypertension and how severe that condition is, plus how severe the RV dysfunction is.
Right. So let's move on to the procedure planning and procedure imaging, and how you navigate to help the interventionist complete the procedure.
Yeah. So I think communication is key with the interventional cardiologist. So the interventional echo person plus the interventional structural interventionalist need to have a very good relationship. Very good communication is very important. Interventional cardiologist understanding of the procedure is very important. So in terms of procedural planning, we tend to go through the anatomy of the patients beforehand. If we don't have that data available, we obtain all the anatomy first, and then have a discussion about the approach of the intervention. So for example, for tricuspid TEER, we'd be discussing where we might be placing the TEER devices, whether anterior septally, very close to the commissural edge, or whether more centrally. So we have a good discussion before where these devices will be deployed and how many devices we might need. So those are the key elements of the discussion.
Yeah. Is patients who have pacemaker or ICD leads, would that be considered a barrier for you to see properly, or for the clipping or replacement of the valve?
So I think the key thing is with these leads being in place, as long as we can see the tips of the leaflets on the transesophageal echocardiogram and the presence of a leak, we will be able to try and target those areas with the edge-to-edge repair devices. When it comes to replacement, it's a different issue. The leads aren't so important. They get usually put aside or jailed. And I think the presence of 3D ICE as well now for tricuspid edge-to-edge repair and in patients who have leads may also help in those sort of scenarios too.
Right. Final question is: do you think ICE will change the way we do tricuspid, and we're going to be eliminating TEE?
So I don't think it'll eliminate TEE. I think 3D ICE would be complementary. I think the wider field of vision seen with TOE or TEE is not present with ICE as yet. It's a much shorter visual field that's seen with ICE. So I think to get a total picture of the success, you'll still need to do TEE. But the TEE probes now are also quite small. Some people have done them with tricuspid HLH repair with sedation and a small pediatric probe, which gives you fantastic quality images. So I think they will still be complementary. I don't think it's time as yet to eliminate TOE completely.
Yeah. Well, Dr. Ali, thank you so much for your insight on the imaging and the role of imaging for tricuspid valve. Watch these videos and others on your YouTube channel and the website. This is Shadi Alraies coming to you from Riyadh Structural Heart Conference 2025. Thank you so much.
Thank you very much. Thank you.